afternoon. Thank you for attending this month's OCHIN Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to have Dr. Ian Bennett of the University of Washington and Dr. Rachel Gold of OCHIN and Kaiser Permanente Center for Health Research here to present the MIND-I trial of longitudinal remote consultation as an implementation strategy for collaborative care of perinatal depression and risk of suicide. Dr. Ian Bennett is a family physician providing full spectrum primary care, including obstetric, family planning, pediatric, and general adult health care with particular expertise in perinatal depression. He is a physician scientist who has focused his scholarly and clinical career on the delivery of integrated mental health care and primary health services to vulnerable populations in the US and in developing countries. Dr. Bennett has expertise in implementation science and the use of strategies to support implementation and dissemination of evidence-based practices for behavioral health integration and the enhancement of mental health services in primary care settings. Dr. Rachel Gold is an epidemiologist and health services researcher. Her work focuses on using health information technology to improve care quality in public clinics and the implementation methods needed to support adoption of such technologies. Dr. Gold has partnered with the OCHIN Practice-Based Research Network since 2005. She now has a joint appointment at the Kaiser Permanente Center for Health Research, where she is a senior investigator, and OCHIN, where she is the lead research scientist. Her work includes studying how to implement a multifaceted quality improvement initiative that improved cardiovascular disease and diabetes care in the Kaiser Permanente setting. She's also studying the adoption and impact of innovative point-of-care shared decision-making tools on cardiovascular disease outcomes in community clinics. She also pilot-tested electronic health record-based tools for collecting and acting on patient-reported social risks, and is now studying how to help community clinics implement systematic social risk screening and how to use patient-reported social risk data in clinical decision-making. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the Q&A or chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Ian Bennett and Dr. Rachel Gold for the MIND-I trial of longitudinal remote consultation as an implementation strategy for collaborative care of perinatal depression and risk of suicide. Dr. Bennett, Dr. Gold, the floor is yours.
Thanks so much, William. I really appreciate that. Sorry for talking over you and that excellent presentation or introduction. This is really super exciting for me to come back. I'm a huge fan of OCHIN for many different reasons, and gotten even more so over the last 6 years as we have run this MIND-I trial through, which was an R01 NIMH funded R01 studying implementation strategies for evidence-based intervention. Rachel was reminding me that I did give a grand rounds along with Rachel at the beginning of this project. And so this is really a neat thing to be able to come back and talk about the results, which are really right off the presses. I'll be presenting some things that have not yet been presented in other venues or in papers yet. So we've just been wrapping up the study and getting the data ready and things of that sort. Rachel, is there anything else you'd like to say? I'll just go on to say that I am a family physician and I'm in the departments of family medicine and psychiatry, as well as global health at the University of Washington. So we'll be going through background of perinatal mental health, MIND-I, and what that work, we refer to it as a project because of the R word, the negative impact of using the R word, or as in research in clinical settings, and how that can create a kind of allergic response in clinicians, which I totally relate to. So we try to stick with project whenever possible, but it was a research project. Then we'll talk about the outcomes and some next steps in the question and answer. These are the learning objectives for this particular presentation. We'll be talking about the significance of common mental disorders, risk of suicide in the perinatal population, cost of implementation of collaborative care models. CoCM stands for the collaborative care model in community health centers, and factors that are associated with successful implementation of CoCM for perinatal mental health. So to start, it's perinatal depression. Many people will instinctively think of postpartum depression because we have some cultural blinkers on our minds, which were really left over from a 19th century idea that that being pregnant was actually a protection against depression, that you couldn't get depressed in pregnancy, and actually the term "the glow of pregnancy" was described that. We use it differently now, but that was the original meaning of that term. We now know that pregnancy is not protective, and women are just as likely to have depression in pregnancy as postpartum. Actually, the severity of symptoms can be higher in the late pregnancy period than postpartum, although it's pretty much, late pregnancy, postpartum are generally pretty high for women, or immediate postpartum. And what we mean by perinatal is pregnancy in the full year postpartum. So that sometimes is a new concept to people. But we know that, for example, death by suicide, which is most often seen in women who have a diagnosis of depression, is most likely from 6 months to 12 months postpartum. And it is considered by the maternal mortality review panels of the CDC and other statewide panels, is considered to be associated with additional risks that come along with pregnancy and having a young child. So death by suicide is also a leading source of maternal mortality. It's in the top 10. It's the leading source all by itself in many studies, and which is interesting, for the US, that we've been able to control mortality in other sources, from other sources in the maternal period, well enough that suicide is now, although luckily it's quite rare, it is a leading cause, if not the leading cause, of perinatal or maternal mortality. Postpartum depression increases the child's risk for lower cognitive and linguistic development, increased interpersonal problems, and impaired physical development in countries where food resources are not easily attainable. So in low and middle income countries, you can see a decrease in growth trajectories. But in countries like ours, where calories tend to be falling out of the sky, except now that we have a formula crisis, which is an interesting issue. We do see these developmental issues and the impact on mental health of the child up into adulthood, independent of other kind of risk factors that would just be genetic risk, for example. So, and there's actually some evidence, I put postpartum in here, but actually exposure to depression in pregnancy also seems to have impacts on the life of the kid. So let's talk about the Maternal Infant Dyad Implementation study, which is what we refer to as MIND-I. You can see our logo up in the upper right-hand side there that is meant to represent an eye, like an eyeball, meaning that we're looking at it, the mom and the baby. And we also have these arrows going around, which represent the quality improvement, iterative work that's necessary to make practice changes. So that's the meaning behind that MIND-I logo. It is a NIMH R01. It's referred to as a type 3 hybrid implementation effectiveness trial for longitudinal remote coaching, LRC, as an implementation strategy to improve the success of perinatal collaborative care implementation. So that's the meaning there. And type 3 hybrid just means that we're primarily looking at implementation outcomes, but we are also looking at the outcomes for patients to make sure that the model we implement is actually working as we expect it to. It's a cluster randomized implementation trial, meaning that a whole clinic was implemented rather than having individual patients randomized to one condition or another. And it's really at base, it's a quality improvement initiative to help screen for and treat perinatal or prenatal and postpartum depression in primary care clinics. There, in the end, we had, originally we had planned to have 20 OCHIN clinics as part of this trial, but we ended up needing to go outside of OCHIN for the second 10 of the sites, and we'll talk a bit more about that. So the collaborative care model is an evidence-based integrated behavioral health model in which there are, if you look over on the figure on the right, the normal relationship between the primary care provider and the patient, that would be the classic interaction, is enhanced by in a team approach by the addition of a behavioral health care manager and a psychiatric consultant. And their work is facilitated by a registry, and those together are helping the primary care provider remain the leader of the services delivered to the patient for common mental disorders. So primarily depression, anxiety, but also the identification of risk of suicide. And that model has been shown, is highly evidence-based, more than 80 high-quality randomized trials overall showing great benefit to the patient as compared to usual depression care in the primary care setting. It's also been shown equivalently, not in 80 trials, but in enough to know that it is also effective in the perinatal population. However, it hasn't been widely implemented, despite the fact that the health services and healthcare and services administration, Health Resource and Service Administration, excuse me, HRSA, and CMS, the Center for Medicare and Medicaid Services, have promulgated codes to pay for this service because they want practices to move towards this model. That actually got implemented after the beginning of our trial. It's relatively new, but just to indicate just how robust and highly sought it is as a model of care for improving the outcomes for a population of patients rather than just individual patients. So the question is, although this has been shown to be important and there are now codes to support it, it's not widely implemented, and it's been found to be pretty difficult to implement. So the question for this trial was, how can we influence the improvement of implementation of this model? Longitudinal remote coaching, or LRC, is a particular intervention which is targets. You can see the top of this model is that same one, or this image is the same one I showed in the previous slide, but not colored. And down below, you see the influence of a coach, which would be a version of a practice facilitator, so an implementation coach, but which is focused on this particular intervention and is focused in particular on the role of the work, on the work of the behavioral health care manager interacting with the psychiatric consultant. Because this team here, that when they're new and they are new to this model of care, they get training, but we know that that training is a good number of these teams don't end up being able to really implement the model of care. And so we are working to support their learning of this model of care and be able to take it on. And the conceptual framework behind that is that once they really get it, understand what's going, they will find it so rewarding and satisfying that it'll just go on its own, but they need some additional support. So it's intervention specific. It's focused on systematic case review. There are initially weekly meetings because the meeting between the healthcare manager and psychiatric consultant do happen weekly initially, well, actually weekly forever. And so the coaching starts right at the beginning and provides observation and feedback and a rating of competence, which this team can both use to learn from and improve their skills, and also to go on to, we are able to kind of assess how people are doing, the teams are doing as we go forward. That's described in a paper that was generated as part of this project in 2019. So the longitudinal remote coaching components, as I'm describing here, you can see there's a It complements the generalist practice facilitators. You guys at OCHIN have facilitators that help with implementation of various interventions. But generally that would be applicable to any different kind of intervention. So this one is really specific to collaborative care, and it's longitudinal, so over time. The principles are around ongoing interactions, specific and timely feedback, multifaceted training, and overcoming barriers to implementation at that particular site. So the psychiatric consultant and the care manager can work together to overcome those obstacles. And the skills development techniques include modeling, so having the psychiatric consultant, the coach be able to model how exactly to do this, providing behavioral rehearsal, so practicing before actually working with patients on how this team works together. Space practice, so it's not just all at once, but is over time. As people get better at it, they get additional feedback. There is direct feedback, observation, and fidelity monitoring. So, and that's all based on theories related to consultation. Actually, is within the implementation science world, it's considered a consultation model. All right, so the setting you guys are very familiar with, OCHIN sites. We're looking for primary care community health centers providing perinatal care with at least 50 deliveries per year. We're interested also in the pediatric side, but we use as our recruitment strategy looking at those sites that had pregnancy, so prenatal care. And it ended up including 10, as I mentioned, 10 OCHIN, 10 non-OCHIN sites recruited in 2 main waves of recruitment. This is for the entire study. You can see it's quite diverse and national, the sites that were included in the final trial sample. The implementation timeline, we had a pre-implementation period of 3 months in which the sites were organizing their implementation teams, working with a coach to get the site ready for launch of care. There was then, at the end of that time, a intensive training that was generally 2 days long on site with a team from the Ames Center of the University of Washington, which really focuses on doing the collaborative care model training. And that was followed by a launch and implementation, more intensive work of implementation support, which lasted 12 months. And then we call it a sustainment period of 9 months. We now know that that implementation really, continues for up to 2 years. Pretty normally to really get a model like this, a complex model like this really in place. But these were the activities that were going on. So there was more intensive support in the first 12 months, 15 months, really, the first 15 months, followed by a little bit less intensive support. There were QI reports generated through this period as well. So people had information on how their own site was doing. We use as an outcome measure for implementation the stages of implementation completion, which is a tool that Lisa Saldana and the OSLC folks there in Oregon developed for implementation more broadly, and we created a targeted one for the collaborative care model, but these are the general stages. You can see that you start from engagement, which is really going out and reaching out to clinics and trying to get them interested, them understanding feasibility, and then they actually go on to start their readiness. They adopt it. They say, okay, we're going to do it. And then that's at stage 3, and then goes on through the implementation phases, and then finally an assessment at stage 8 of competency and moving on to sustainment. And we use this with anchors to be able to determine how well each of the sites is doing with implementation. Okay, so this is a randomization. I should tell you that we randomize at the clinic level, not at the patient level. But this is showing you the number of patients that were included in the two arms of the randomization. And you can see there's kind of a surprising outcome, which is always a risk when you randomize at the clinic level, which is that you will randomize by chance clinics potentially to one arm or the other that have more patients in them. And that's what ended up happening here. You can see that over the study period, there were 9,168 women who were getting prenatal and postpartum care within the clinics we were working. But 2/3 of those actually were in one arm, which was the intervention arm. And you'll see some other consequences of that difference in balance. But anyway, this is the way it ended up. And you can see that so it's 6,400 women in the intervention arm and 2,758 in the control arm. You can see that of those are women that were eligible so that they could get depression and they could be identified and they could get treatment, which is what is represented by the mind-eye boxes at the bottom. So you can see that of the 10 sites in the control arm, over the 2 years that they were working on this, they ended up treating about 200 women, 189 women. Whereas in the intervention arm, we had 400 women. And that's, as you can see, the proportion of their total eligibles was 6.9 in control and 6.4 in the intervention. So about the same between the two. We did stratify randomization. So we made sure that there was an equal number of clinics, I should say, sorry. If there was more than one clinic in a state, we forced the randomization to push them into different states, either into the intervention or control site. And we also stratified based on whether they had a relatively high level of existing integrated behavioral health or low level. So those two things constricted our randomization. So because we believe that those would be important things to have balance between the two randomization arms. So there's a lot of information on this chart, but you can see that there's over on the right is whether or not there's a difference between control and intervention arms by these demographic variables. And you can see that all of them at this high number of 9,168, that all of them were different significantly, but you should use that, I'd say, with a grain of salt. So for example, for age, the difference between control was 29.39 years and intervention was 30.82 years. That really doesn't matter, right? Those are, the same age, but it was because there were so many of them, and the way we did this analysis, it was, significant. We'll probably do some modifications to this to do categories, so it's a little bit less. But anyway, there was a really important difference that I wanted to point out in the African American and Latinx, so African American so-called race and Latinx, the Latinx ethnicity. That here, where you can see that in the control arm, there was 87%, I'm sorry, 46%, so 87, so 46% in the control arm were African American versus 14% 3% in the intervention arm. And that was kind of reversed, where it was only 10% Latinx in the control arm versus 27% in the intervention. So that's worth paying attention to, because in general, Latinx women in pregnancy and postpartum have been found to respond better in studies previously than African Americans to the collaborative care model. They both respond. I want to, and better than control, but there is a difference between those groups. So something that could impact outcomes of the intervention. The parity also was, the difference was 13.2% versus 12%. So even though this is significant, it really doesn't matter, those two things. One thing we did notice was that does matter. There was twice as high a percentage of women in the control arm with a history of depression, but more women in the intervention with a history of anxiety. So, that's a little different. The collaborative care model is treating both of those. And then there were, otherwise, it was fairly similar across the two, but there were some differences. Then within 100% poverty, 47% in the control and 36% in the intervention. So somewhat different there as well. This is a graphic showing the implementation of screening for 6 of the 10 OCHIN sites. I just kind of like the figure, and it's very illustrative of the change in rates of screening that you can see, that we saw over and over in all of the OCHIN sites in particular. They did a really great job of moving from a quite low screening rate that was, actionable, meaning it was ending up in the electronic health record. And by the way, of course, women are supposed to be screened in pregnancy and postpartum. We did have a protocol that was a little bit higher bar than the usual screening protocol. So this is the rates of screening for over the course of the intervention following this CQI iterative quality improvement approach that's represented by that graphic at the bottom there. You can see that the sites did really well for improving screening, which is awesome. So this is a drum roll. These are the main outcomes for the trial, never before presented. It's a little bit of a complex table, or can be, but over on the left here, up and down, we have the control sites versus the intervention sites. So you can see that there are 10 of those over on the right each, and that represents 50% of the sites in each one. And then on the top, this is the competence. So that was our main outcome. Were the clinics able to implement their collaborative care model to competence? And we wanted to see whether LRC, that's the intervention, improved the number of sites that got to competence as compared to the control. And what you can see, and it's reflected in our statistical assessment down below, that it didn't. We did not find a benefit, and this is the intent to treat. So if you got randomized to get the intervention, then this is what happened. And you can see that it was 50%, 5 sites not competent and 5 sites competent in the intervention arm. Whereas actually it's a little disconcerting that 6 sites in the control arm versus 4 sites were 6 sites were competent in the control arm versus 4. So, but anyway, they're not statistically significantly different. So we had a negative trial for that angle. So we weren't able to show a benefit. However, there were, one of the things that's been complicated and interesting about this trial is the longitudinal remote consultation only gets started after a site launches care and if they engage with our intervention. So it's not fair to assess whether or not it made a difference unless they actually got the intervention, right? So that's a different bar, but worth checking. And you can see here that the sites that got 2 or more LRC sessions, which our experts said was like a minimum that would help sites go forward, and actually most of them got a lot more than 2. Then you can see actually that there is a trend. Although it's not reflected in our p-values, there were more sites. So 5 sites in those that got some exposure to LRC were competent compared to 3 that did not. and it was 50-50 in the control arm. So, that's meaning that they didn't get any LRC. Something to at least take a little bit of hope that there is something to this, and it gets to, our issues around having only 20 sites in the trial. Okay, so yeah, there's the money shot there. Okay. So I wanted to go on to talk a little bit about the implementation measures. We have had dig into the collaborative care SIC a little bit. It includes 91 individual implementation activities in 8 stages. I sort of talked about that a little bit. It's date-driven and yields scores of duration, like how long you were in each of those stages, the proportion of the activities that you think should be done that actually get done, and then a stage score of how well they did overall, in accomplishing that. So you can see that there are a bunch of different activities for the mind-eye version of this. 3 had to do with engagement, 5 with assessment of feasibility, 28 with readiness planning, a lot of readiness planning. That's in the pre-launch support, then in-person training, then implementation support and sustainability planning, and then reduce support where you get to competency. So there's a lot of different activities, and most clinics do not do all of them, even those that are successful. This is represented. I just wanted to talk about how great I like this. I think this tool is, and recommend that people talk to Lisa if you're thinking about what would be a good way of assessing implementation processes. You can see this is kind of representing the in colors, so we won't go to all the details, but it allows you to look in quite a granular way at what's being done at each site and monitor that. And you can actually give feedback to the sites using this. We ended up not doing that in this particular project. We used other ways of giving feedback, but it can be used for that. So of the 20 sites that agreed to participate in MindEye, 18 or 90% launched a collaborative care program defined as enrolling at least 1 patient in the program. They got more than that, but that was our definition. And 11 or 55% achieved competency in collaborative care. I will just, as an aside, point out that that's what we see in general for implementation of collaborative care. Even with all the work that gets put in there, it's hard for sites to get that in that time frame anyway. So the SIC findings with regard to the OCHIN sites, just focusing on the 10 OCHIN sites, there were 85 clinics approached, and April and Rachel have been working on kind of defining this a little bit better. I'll just call that out of it. Really appreciated all the work that got done on understanding how, why the so many sites declined to participate. But anyway, 76% didn't agree to go on during that pre-implementation. So almost 86% did so during stage 1, which is finding out about the intervention and deciding not to participate. Another 6% almost discontinued during feasibility assessment or stage 2, and then 4% during stage 6 at the point of program launch. So there was only a total of 18% successfully launched a collaborative care program. Okay, so another really important part of thinking about how to move forward with disseminating and understanding whether collaborative care can and should be implemented. A lot of resources put behind, we know that it makes a difference if it's implemented, but is it possible to implement, and at what scale, and what can help? One of the things that makes a big difference to people about deciding whether to implement is the cost to the clinic in time and effort put into this, which might be, for example, lost revenue for patients being seen, or the amount of time that that the different team members need to spend on implementation that could have been done in other activities. So we wanted to get a pragmatic assessment of the cost to the clinics in participating with this particular project. So the COINS is a tool that is developed again by Lisa and her team to match the sick and allows you to systematically collect information about cost. So our purpose of our analysis was, as I mentioned, thinking about what the cost would be to a clinic. And we wanted to estimate the cost of health centers, not including the cost of the grant, that was funding all the other activities. But we did, get that money, so that information to help with our planning for going forward and to help with future project design. So there's lots of important stuff in terms of how exactly you collect the information. It's fairly straightforward. You look at the amount of time, who was spending that time, and what their salary is, and then you estimate the cost based on that. All right, so here are the 10 sites from OCHIN and the duration of time that they were involved with the project, the highest 6th stage that they got to, whether they became competent, and the number of patients that participated. And then the average hours per stage of implementation that actually they were involved with. So you can see that a number of hours went from 2 and the all the way up to 241 in the various for administrative support. Or I mean, across these domains, what am I saying? So, there's, you can see that it varies across the different sites. Some sites that really never got going very much. There's not a lot of hours in there. And, in general, there might be less hours in administrative support, et cetera, than in other sites. So the idea is to be able to see, like, where, for the sites that succeed, is there something we can learn from this? This is a representation of the costs per stage of implementation and by the sites. The red ones are the ones that reached competence. The blue ones did not reach competence, and then the gray ones discontinued early on. So the important thing that I think is really interesting here is that there is a much narrower range of costs among the sites that achieved competence. So these 3 sites here, than those that didn't. So, you went all the way up to $105,000 in cost to the clinic, and all the way down to virtually none, for the sites that never achieved competence. So, there's I think some interesting things to learn about that, like, maybe some warning signs about things not going well, or, they're either working really inefficiently or not working at all. So some interesting stuff to see visually there. What we ended up with was that the total cost to the sites, if there's a mean over here, is about $40,000 for a site to implement collaborative care through the period of time, among these 10 sites. So over here is the clinic, funds, and it goes, from 4,000 to 103,000. But the sites that became competent, it really was right around $41,000 that they needed to spend in their, time. Not that they were spending cash, but they, were investing in the time of their staff. So that's, an important number for us to understand, especially as we think about what the incentives should be, to cover the cost of a site participating. If over on the right here is the cost to the other funding, which ended up total per site about $85,000. So that really helps us with kind of budgeting we should think about we need for these projects. And one thing to consider, though, is that it is cheaper in these sites than if they were to work individually. Working in a cohort saves money because you get training all at once and things of that sort. So it's actually estimates for individual sites working with the AIM Center, for example, are higher. So you save a little bit of money by working in a group like this. Okay, so the last thing I wanted to talk about was some factors related to success that we learned. And this is looking at all the sites, again, within the OCHIN. Well, actually, this is all the 20 sites. And we use a methodology called Qualitative Comparative Analysis, which is a means of bringing some quantitative analytic approaches to qualitative data, which is is done through some interesting things related to set theory, and it's really kind of interesting and popular, more and more popular methodology among folks who do mixed methods evaluations of things. And you start with asking what conditions or factors alone or in combination, so you can get this synergy with other conditions and factors, are necessary or sufficient. So if it's sufficient, then it's all by itself, or necessary, you have to have that in order for the success to produce a particular outcome. And it rests on the idea of a causal complexity. So a lot of different factors can work together to result in that outcome. And the outcome we were looking for was whether the FQHCs achieved competence in collaborative care as measured by the stages of implementation completion measure. So we went into this using conceptual models, thinking about the issues of leadership, staffing, resources, goals, and experience with collaborative care or other integrated behavioral health. Each of these is well known within the implementation world to influence outcomes of implementation and their interventions to try to address them. We gathered the data from the sites primarily through qualitative interviews. So we did qualitative interviews of each of the sites participating at multiple stages of their implementation. So there are 112 interviews completed across 17 of the MindEye sites. That's true, I should say. We didn't end up with all 20 where we were able to get interviews done. So we limited our analysis to the 17 where we could get some data. All sites were staffed with care managers throughout the duration of the study, and 82% had formal project leaders or psychiatric consultants. So the results, I guess these are results, sorry. So we found that the 82% were able to maintain these. So as far as the staffing goes, they had formal project leaders, physicians, and or psychiatric consultants involved with overall. Okay, so our QCA modeling based on the qualitative results in our conceptual model and theory resulted in conditions considered sufficient for sites achieving competency. There were 7 which were considered sufficient. So that included having a formal project leader, and the higher the consistency score, the better. So anything above 50 is considered useful, although 60 and above is considered a little bit better. Tangible support from leadership. So, those folks who are the CEOs and things who are, actually representing some kind of emphasis on the importance of doing this. Leadership familiarity with MindEye. So did the leadership actually, even know it was happening, which surprisingly, and a good number of sites that are doing implementation, the leadership may not know that it's even happening. Consistent staffing by a psychiatric consultant was very important for this. Dedicated resources and materials, and having at least 20 enrolled patients at some point, which all of the sites had the capacity to do that, but not all did. But these were the sufficient conditions for achieving competence. So conclusions for my overall presentation. We did not find evidence for implementation benefit from the LRC, although there was a trend for benefit when limiting to those sites that actually received LRC compared to those that did not. The cost for implementation of collaborative care averages for perinatal mental health averages around $40,000 in salary coverage, but ranged widely. And factors associated with successful implementation were consistent with previous work in implementation science, but included a caseload experience minimum, that they actually got enough patients to be able to know how to do this, which has been hypothesized within the collaborative care world, but hasn't really been a big part of the implementation science kind of more broadly. So that's kind of an interesting outcome. But leadership and staffing and a minimum size of practice may be needed for this model really to succeed. So next steps, we feel like additional trials of LRC are needed to be able to really assess whether it makes a difference. So larger number of sites and waiting until the sites are actually launched before an LRC can make a difference within your sample size. Our trial in the end was underpowered to be able to detect that difference. There was a really interesting spin-off of this project. We were funded in California by the California Healthcare Foundation to add some sites to our trial in California because they were interested in collaborative care. And as a result of the success of that work, they are now funding a citywide or countywide project within Los Angeles, where nearly half of all Medicaid-funded deliveries in California occur in Los Angeles County. So we're going to be working with the federally qualified health centers of Los Angeles County in collaboration with the Community Care Association of Los Angeles County, the professional organization that supports them. And there are OCHIN sites included in that county. It'll be a 5-year project to implement collaborative care for perinatal mental health in those settings. It's not a research project, it is an implementation project. And really excited about that. And you guys should really feel good about helping us be able to, what I believe will be have a big impact on women's mental health. Really interested in some interesting things I learned recently is that the collaborative care perinatal depression registry that we built into the OCHIN EPIC registry is being used by new sites that had not been part of MindEye. Not many, but they've made some modifications to it so they can use it for the general adult depression practice. And so we're starting to collaborate with them, think about how they modified it and how we might be able to help OCHIN take that on as a product and really promote that more actively, since there is good revenue to be gained by billing for the collaborative care codes, and you need a registry in order to do that. So you can, OCHIN could use that as a product to attract more customers to the network. And then we're working on perinatal suicide risk determination and care. We got an administrative supplement towards the end of our project to look at some of that data, and we're hoping with your collaboration to move forward with subsequent R01s, looking at the ways to enhance detection and management of women with risk of death by suicide, which I mentioned is a leading cause of maternal mortality.